Okay. Okay, it looks like it's working. So I wanted to welcome everyone that's watching for our second lecture on the All Things HV series. We started last week with the topic of minimally invasive distal pancreatectomy, and we're continuing this week with bile duct injury. We are really lucky to have three distinguished speakers participating with us today. We have Dr. Edwin Onkendi coming to us from Lubbock, Texas. Dr. Iswantu Sukandi coming to us from Tampa, Florida. And then Dr. Rohan Jayaraja coming to us from Fort Worth and Dallas area. And for those of you that probably don't know me, my name is Edward Joe, and I'm a HPB surgeon here in Dallas, Texas as well. So we're going to get started with our talk. Dr. Onkendi is going to get started with us first with a talk on early repair for bile duct injury. Sir, all yours.
Okay. Can you see the slides?
Yes, sir, we can.
All right. Hello, everyone. Thank you for joining us for this week's SAGES HPB webinar. I hope everybody is staying healthy and safe. My name is Edwin Onkendi from Texas Tech University in Lubbock. I'm going to discuss early repair of bile duct injuries. I have nothing to disclose. The objective for this talk will be a review of the mechanism and classification of bile duct injuries. We'll discuss identification and workup, indications for early repair, operative strategies according to type, as well as a few tips and tricks. I believe most, if not all of us, are familiar with the most common classification system, which is a Strasbourg-Bismuth classification system from type A to D and E1 to E5, with the E1 to E5 being highlight injuries. In this system, they also define a vascular biliary injury as a ductal injury, as well as a hepatic and or portal vein injury. In this current laparoscopic era, the most common mechanism of injury is a surgeon retracting the gallbladder a little too hard, in the process aligning the cystic duct and common hepatic duct. And so the surgeon ends up clipping the cystic duct here and the common duct, these two sides, and consequently amputating the common duct with the cystic duct. The resultant injury is the most common type that we see, which you have a long missing segment of the common hepatic duct with varying degrees of injury to the hilum and even separation of the lobar ducts, sometimes with a vascular injury as well. This is an example of a patient I took care of with this classic injury. Here we can see the proximal common hepatic duct. There's a missing segment from the distal stump here, and also an associated right hepatic artery injury with a long missing segment. In terms of identification, only about a quarter of these injuries are identified intraoperatively, either through an abnormal cholangiogram or sometimes the surgeon realizing he has clipped more than one duct. Post-operatively, they tend to present with a bile leak, a bile fistula, jaundice, and sepsis, as well as persistent pain. Rarely, when they present months to years later, they may have atrophied liver segments, liver abscess, or intrahepatic lithiasis. This is another example of another patient I took care of. Here you can see the IOC during a lap cholecystectomy. The cholangio catheter is fairly high in location, and the cholangiogram is not really adequate because there's an under-opacification of the common hepatic duct. This patient post-operatively developed jaundice on day 4, and we took him to the operating room and found on a pre-repair cholangiogram, it was a type 4 injury with an associated tangential injury to the right hepatic artery. In terms of workup, Ultrasound may be of utility in some cases, especially the obstructive injuries, where you may see biliary intrahepatic biliary dilation. Sometimes it may show a biloma from bile. CT with IV contrast is probably most useful for identifying associated vascular injury. Otherwise, in terms of detailed workup of the injury, cholangiography, either with PTC, ERCP, or MRCP, is the best option. Now, MRCP is better than the PTC and ERCP because it's non-invasive, shows you the proximal and distal anatomy, unlike the PTC, which shows proximal and in most cases, and ERCP, which often shows distal anatomy. This is an example of a PTC cholangiogram showing a type E2 injury. This image and the last image are from the same patient who had a bile duct injury as well. Preoperative MRCP is very useful, especially for repair, because intraoperatively, from a repair cholangiogram, you can compare the images and make sure that all ducts are accounted for your repair. Considerations prior to repair. The key factors are these listed, especially defining the anatomy. We know that only about 57% of patients have the classic biliary tree anatomy, and the others have varying degrees of anomalies for the biliary tree, the cystic ducts, or both. Also, it's very important to characterize and define the extent and detail of the injury before repair. Sometimes you need to manage sepsis, and it's important to define associated vascular injury as well. Now, early and ready to repair have been variedly defined in literature. However, in general, early repair is repair done within days to a week. Delayed repair is more than 6 weeks. Rarely, intermediate repairs are done within 1 to 6 weeks. Ideal patients for early repair are those who are identified immediately during the cholecystectomy. Early referrals, patients with minimal to no sepsis or inflammation, and those patients who are stable. And early repair is associated with lower costs of care, patients returning to normal activity sooner, and a better quality of life. This paper from UCSF probably summarized the decision best by saying that in terms of timing, as long as 4 key factors are met, conditions are met, timing wasn't a factor in their study for outcome success. So these factors are complete eradication of intra-abdominal infection, full characterization of the injury by cholangiography, correct surgical technique, and repair by experienced biliary surgeons. As long as these 4 conditions are met, they show that timing wasn't a major factor for outcome. So if you've identified a bile duct injury intraoperatively, what next? If you're the primary surgeon with no biliary experience, it's not ideal to convert just for diagnosis, exploration, or drainage, unless you're converting to control major bleeding. In that situation, place a drain. If you can, place a catheter to the proximal duct, you can, and then refer the patient for experienced repair. It's not the time to do the once-a-year hepatic oliginostomy. Unfortunately, data shows that about 75% of previous repairs have been attempted by general surgeons without proper bile duct experience. And unfortunately, repair success is inversely proportional to the previous attempts to repair. But in general, as a primary surgeon who caused the injury, mentally, it's not the best time to be involved in the complex decision-making and management of a bile duct injury. An example is this patient I took care of. Now, in this pre-op MRCP, it looks like there are 2 ducts with a confluence and a missing segment of the common hepatic. Now, if the primary surgeon who caused the injury takes the patient to the OR and does a cholangiogram, he sees the 2 ducts with a confluence, they will think this is a right and left hepatic duct and do an hepatic oliginostomy. However, what they'll miss is these are left-sided hepatic ducts, the right anterior and posterior ducts are totally separate from the right duct. So it's a complex injury to repair, which required separate anastomosis. Further, repair success is dismal for primary surgeons and with a high failure rate compared to biliary surgeons. And this is the same regardless of the timing of repair. So if in terms of intervention, if you identify the bile duct injury intraoperatively and you're experienced, if it's immediate, control the bleeding and repair immediately. Obviously, the patient is stable. However, if they present post-operatively and the 4 conditions I mentioned previously are met, then assess for any hepatic dysfunction and major flow defect from vascular injury. Rarely, there's a major defect. In that case, a patient may require resection or liver resection with ductal anastomosis. This scenario is rare. However, the common one is preserved liver function and perfusion, in which case the repair option is hepatic oliginostomy with liver preservation. It's just an example of a flow, major flow defect. The right hepatic artery has been clipped here, and there's a hypoperfusion of the entire right lobe of the liver, in which case liver resection probably would be the best option. Quickly, in terms of the repair options for type A, these are easier to manage. If recognized during surgery, small ducts you can suture ligate and drain. If it's post-operative, they're easier to manage with bile duct stenting and drainage. Type B injuries, they don't tend to present early for early repair. They tend to present later, but if by chance you identify them intraoperatively, then you can do a hepatic oliginostomy or resect that involved segment. Type C, again, it's an aberrant duct, as we know. It depends on the size of the duct. If it's a sizable duct, then you should do a hepatic oliginostomy. If it's a small, very small duct, then you can ligate. Type D injuries, if intraoperatively recognized, you can close over T-tube, ideally with a separate choledochotomy for the T-tube. If it's a large defect, then hepatic oliginostomy is probably the best option. Post-operatively identified injury, then you can manage with a bile duct stent and a drain. Type E injuries, probably best repaired by hepatic oliginostomy, sometimes with a different anastomosis if the ducts are separate. Just a brief review of my experience here in Texas Tech for the last 3 years. We've had 27 referrals, but for bile duct injuries. 24 have been operatively repaired. 63% were type E injuries, and over 80% were repaired within the first week, as you can see down here. Follow-up more than 6 months, and so far, fortunately, no strictures have occurred. So in summary, a few tips here. The main thing is to ensure, a well-perfused duct stump. For high injuries, you can gain more duct by lowering the hilar plate. As you can see on this picture, this is a hilum, the base of segment 4. You can either retract it or you can resect to gain more duct by extending the orifice to the left duct. If two separate ducts, you can join them by recreating the septum to get a wider orifice instead of individual anastomosis. If you're using a T-tube, you may, the best thing is probably to do a separate choledochotomy and from the injury site. Obviously, like any anastomosis, the key is minimize tension by having an adequate length of a ruling and properly routing it to minimize tension. And lastly, for high or difficult injuries, small ducts and thin walls, it's probably best to stent either through a PTC or a Transrolling stent as this one. Okay, thank you.
Thank you very much for your talk. That was great. I just wanted to mention that from our comment section, Dr. Kevin Hayek just shared a paper from surgical endoscopy in 2019, looking at a survey of patients, and it looks like from that paper, over 90% of the patients would be in favor of getting transferred to a higher level center for these bile duct injuries, like Dr. Onkendi was saying during his talk. A quick question for you, sir, before we move on to the next speaker. When you get a transfer for these bile duct injuries, what's your standard in terms of your workup? And is there any case where you just take the patient to surgery without any imaging?
Usually when they get referred, obviously it depends on the timing, whether there's sepsis, associated vascular injury. But if they are referred in with no sepsis, with no vascular injury, and patients are stable, I get an CT abdomen with IV contrast to check for any vascular injury, and then get an MRCP to define the biliary anatomy. The reason for that is to ensure that during repair, we always get a cholangiogram. You can match all the ducts to the images from the MRCP to ensure all the ducts are anastomosed and avoid missing any ducts.
Perfect, perfect. And we're the same way. I think from my last reading, there's a concomitant right hepatic artery injury and a bile duct injury, maybe about 25% of the time. And so our standard here protocol is to get some sort of a CT with contrast and an MRCP as well. Thank you so much for your talk. If you wouldn't mind unsharing your slides, and then we'll move on to Dr. Sukandi. He's going to give us a talk on vascular biliary injury. And while we're setting up, it looks like Dr. Adnan Al-Saidi, coming from UC San Francisco, asked us about a case where we have a arterial injury without a bile duct injury, but I'm going to table that question until after this section of the talk. So, Dr. Sukandi?
Yes, thank you for the opportunity to give this talk. Can we see my?
Yes.
Yeah. Okay. Yeah.
Yes. Looks good.
All right. Perfect. So my assignment for this webinar is management of biliovascular injury after laparoscopic cholecystectomy. A lot of this talk has been covered by Edwin. Good job. Thank you very much to make my life job easier. I want to go a bit fast because I have 3 videos to show you about this bile duct injury repair. So again, laparoscopic cholecystectomy, a lot of cases, and bile duct injury can happen with a vascular injury. As Edwin mentioned earlier, a lot of this biliary anatomy are not standards. Only 75% will look like a textbook. The rest of them is not like textbook. And people always say that the cystic duct can be very short, and you can see here the cystic duct can have a common hepatic duct just next to it, and then if you look at it from outside, you don't know there's a common hepatic duct right here. And the surgeons thought this is a cystic duct, while it's actually not cystic, it's common bile duct. This is the classical injury. I'm trying to be as practical as possible here for this lecture. And like he mentioned earlier, only 50% of patients actually have a classical anatomy where the left duct going this way, right duct goes to the right anterior and right posterior duct. You can see here 12% of patients are Caucasian, 20% actually the right posterior go to the left duct. This is the classical teaching for the fellow. If you do a left hepatectomy, don't pass the stapler right at the bifurcation, but you have to pass the staple right at the base of the umbilical vein because you don't want to catch the right posterior duct. And this is a low insertion of the right posterior duct. The cystic duct should be right here. And you can see the right posterior duct is very close to the cystic duct. Sometimes it get clipped together. So right posterior duct get clipped too with the cystic duct. This is a picture from a surgeon who sent me this picture here. So you can see the right posterior duct can insert very low, and this is the cystic duct stump. You can see it's like a centimeter or so. It's very easy to be confused and get clipped too. This is the classical bile duct injury of Bismuth Strasbourg classification. A to D and E1 to E5. As we can see here, we have discussed about this earlier. And this is the SAGES safe cholecystectomy program. You can see the cystic artery, cystic duct, and there's nothing between. You can see the cystic plate behind it. It is a safe way of doing cholecystectomy, very important for general surgeons doing a lot of cholecystectomy laparoscopically out there. This is another picture that I was sent through an email by a surgeon from the operating room. You can see here, there is no contrast filling the distal common bile duct. There's no contrast into the duodenum because the catheter is in the bile duct itself. The bile duct got cut, so we cannot see anything distally classical. And this is the other bile duct injury. You can see here this is the right anterior duct. This right posterior duct. There's a missing right hepatic duct. Everything else looks normal, but there is a piece of right hepatic duct is missing about a centimeter or so because there's a cut here. So this is not a good scenario as well, because this is usually high in the segment 5 or so of the liver. It's hard to get the distal part of the bile duct visualized. And this is the study after the PTC. Later on, there's a lot of clips. This patient has 24 clips, and this is usually not a good thing where you see so many clips in the images. Now, I want to focus a little bit about this vascular injury, and I learned so much by preparing this talk, actually. So there are 3 elements of blood supply to the bile duct. I think this is a basic that we have to understand. So we can see the common hepatic duct here going to proper. This is left hepatic artery, common hepatic artery, proper hepatic artery, left hepatic artery. This is the right. Right is usually crossing behind the common hepatic duct in about 80% of patients. So this is the element 1 is afferent vessel. Element 2 is the marginal artery. We always talk about the 3 o'clock marginal artery and 9 o'clock marginal artery. I think everybody knows this. But actually, there's also a transverse hilar marginal artery that actually connect between the right duct and left duct. The reason why this is important because, and you'll see later on, because this transverse hilar marginal artery actually help perfuse either the right side of the liver or the left side of the liver, not just the bile duct itself. Will be a bit more clear later on. So, and then the third element is called epicholodocal plexus. This is actually a network of vessels that's actually within the wall of the bile duct. So this is actually the small feeders that keep the bile duct wall alive. So this is a 3-layer of vascular supply into the bile duct. Now, a vascular injury, the right hepatic artery is the most commonly injured, and it's about 92% of the time. So it's only 8% of the time other vessels other than right hepatic artery actually injured. The reason why is because it is located posterior to the area where the surgeon is working. So it's obviously the first artery is the closest artery to cut. Sometimes there is a portal vein injury also with the right hepatic injury. Very rarely portal vein alone is injured on the right side. Sometimes proper can be injured. Even left hepatic artery can be injured on the other side of the porta hepatis, and common hepatic injury can happen too. So I think Adnan probably asked this question just a few minutes ago. Isolated right hepatic injury without bile duct injury. So in this case, only right hepatic injury, right hepatic artery is injured, the bile duct is intact. It is seen about 7% of cadavers, they actually had undergone cholecystectomy. They have only right hepatic injury occur, so isolated right hepatic injury. The true incidence is unknown. Why is unknown? Because a lot of this actually result in non-clinically significant ischemia to the liver of bile duct. So actually nobody knows about it. When you get clipped, the liver looks fine. The surgeons probably didn't even look at the liver, close the case, nothing happened to the patient. The bilirubin stay normal, AST bump up to 200, 300 in about 3 days back to normal. So these kind of cases go undetected. And the right hepatic artery can be seen in 2 types. One is occlusion. It means there's a clip across the right hepatic artery and can lead to ischemic problems to the right hemiliver, or it's a pseudoaneurysm. I'm going to show you a video about this, and this can lead to delayed bleeding. Now, how about right hepatic injury with bile duct injury? We talk about without, now is with. So the incidence varies among the reports. Some report says 12%, some says 61%. I think it's depending on the denominator. However, it's estimated about 20% of all biliary injury. The issues is not all the papers actually mention about checking the arterial supply when they talk about the bile duct injury. So not all the papers are doing arteriogram or CT angiogram to actually study this before the repair. And there's always a bias of reporting. It means usually a bad outcome, but there's a lot of bleeding, artery get cut, it doesn't get reported. Nobody write a paper about, you know, clipping hepatic artery because it's bad. So, and usually the paper only comes out from the major academic centers. Now, we gotta dive a bit deeper. What's the effect of right hepatic artery injury on the outcome of bile duct injury? So there is a lot of disagreement whether the right hepatic injury actually make the bile duct repair worse. Some people said, well, there is an increased stricture rate because you devascularize the bile duct. Some authors said, well, actually not so bad. It's about the same stricture rate. But one fact that we know for sure is right hepatic artery injury causes biliary ischemia, and you know when the bile duct is ischemic, something we cannot see it. You know, if it's not so bad, the bile duct looks good, but it's actually not having enough blood supply. You know, comparing those papers that says increased strictures and not increased strictures, there is an interesting observation here. So the timing of bile duct injury repair is important. If the stricture seems to increase when early repair is done, and the reason why is because at the time of repair, the bile duct ischemia is actually still ongoing. So if the right hepatic artery is cut at one level, so above that, above the cut, the bile duct actually still actively going through an ischemic changes. So if the surgeon is doing an early repair and they just make the anastomosis right at the cut, even clean cut, right at the cut, so that piece actually is still undergoing ischemic changes. So those patients will have a higher chance of biliary stricture. However, stricture seems to be similar when the delayed repair is done, because the bile duct is done having ischemia. The ischemia has settled down. So the surgeon actually removed that part that has been ischemic, has declared itself to a point where, okay, this part is ischemic and this part is alive. So the surgeon actually removed the ischemic part and used the good part to do a later delayed reconstruction. Those patients, they don't have an increased risk of stricture. So I think this is something that I think is important for us to all know about. So when the bile duct injury occur with hepatic artery injury, it may look like E1 or E2, but in real life, because of the ischemia, it's actually become E3 and E4, because I said it's actually higher up. We just don't see it right away. So recommendation is if repairing early, have to consider a bit higher anastomosis. If repairing late, then obviously, you know, you see it by the time you repair it. Now, parenchymal ischemia, it's only about 10% of a patient have clinically significant parenchymal ischemia. And there are two types of parenchymal ischemia. This is from the right hepatic artery injury. The first is slow infarction with formation of liver abscess. It takes about 1 to 3 weeks to see the infarction. And the other type of manifestation is with ischemic atrophy of the liver. It takes months to years. The other side, the right lobe, become a bit ischemic. Nothing happened to the patient again, no abscess, no infarction, but it just become ischemic maybe a year or two later. The rapid infarction, which may end up requiring right hepatectomy, does not occur without concomitant portal vein injury. If it's only right hepatic artery injury, the patient usually don't have infarction. Now, this picture is important. Like I mentioned earlier, there's a hilar shunt from left to right, and there's a longitudinal shunt from this artery feeding to the right and left side of the liver. Why is it important? This is why it's important. If the right hepatic artery is cut right here, and the bile duct is cut right here, it means the marginal artery, the 3 o'clock and 9 o'clock, is also gone. So the only artery that will supply the right side of the liver is the collateral, the hilar marginal artery from the left to right. This is the only one that will supply the right liver. But at least there is still something. Now, what happened with E4? When E4 happened, in addition to the right hepatic artery injury, the right hepatic artery is no longer having a blood supply to the right hemiliver. Now, E4 also cuts both the longitudinal marginal artery going to the right side is no longer there, and the transfer marginal artery also get cut. So the right liver is really ischemic with E4. So E4 is actually a much larger deal than, for example, E3 or less. And I also want to mention that in one of the paper they mentioned from Dr. Strasberg paper that in the animal model, when the bile duct injury is done with clipping, so you see sometimes the intrahepatic bile duct is very distended because it's high pressure. The bile duct, the biliary flow is obstructed. There's an increase in intrabiliary pressure. What happens is by doing that, there is a decrease of portal flow. So now it actually makes it worse in terms of hepatic ischemia in a patient who already have right hepatic artery injury. So it is almost like better to have the bile duct leaking and comes out to the drain. At least the bile duct is decompressed, because by decompressing the bile duct, the portal flow is not decreased, because there's no competition between the pressure in the bile duct versus the portal flow. Now, what we should do if we diagnose the right hepatic artery with the bile duct injury. Obviously, the recommendation is if you catch it early, if you're there, which is probably unlikely, you should try to fix it. Immediate repair of the right hepatic artery, if possible. End-to-end anastomosis can be done, or if there's a missing segment and you have too much gap there, you have to put a little graft there. You can use IMV or other conduit. However, like I said, the opportunity to repair it usually limited, because this is can be done only within like 6 hours or so. And most patients, by the time they get transferred to the hospital, they already usually waste like more than 6 hours. Only 10% of clinically relevant ischemia is actually diagnosed. So some people say, well, there's no really push to fix it because only 10% of patients will have problems. So this is the other side of the argument of a routine repair of the hepatic artery. But for sure, when it's more than hours after, there's really no benefit of repairing it. Now, I want to mention about the portal vein. It's obviously much less frequent than the right hepatic artery injury. I've seen only one portal vein injury after working in Tampa about 3.5 years. I've repaired a lot of this bile duct injury from around the city. It probably underreported. 80% of the portal vein injury also has right hepatic artery injury at the same time. And remember, I mentioned about the hepatic necrosis. When the portal vein is injured with the hepatic artery, 44% of patients develop necrosis of the right hemiliver. And this patient required a right hepatectomy within usually 1 to 16 days. And the mortality is high. It's a 50% mortality with rapid necrosis. It's like planning to do right hepatectomy. You take all the vessels and you don't take the parenchyma out. This is basically leading to sepsis and liver failure. Okay. So this is the first video of the common hepatic artery injury. I want to make it a bit faster to save some time here. So you see, we always check a CT angiogram to make sure we know about the artery status. And this is the intraoperative. This is a robotic repair. We repair this with the robotic approach quite a bit. Uses some blood. You can see clots there being removed. So we can see there is a pseudo aneurysm. There is a active bleeding from the right hepatic artery. This is a pseudo aneurysm. You can see there's a little hole there. So we just utilize 4O polypropylene. We give a bit compression to the hepatic artery and repair it. Obviously, these events can be very dramatic, but with a little mechanical compression, we can usually control it just to give enough time to fix it. It's a lot of blood there. The patient had maybe 1.5 liters of blood into the abdomen. Hemoglobin dropped about 3 grams within just about 6 hours or so. We placed a little liver retractor to free up the arm. And you can see here there's a hole staring at you. We do a Roux-en-Y hepatic jejunostomy. It's quite straightforward. We elevate the transverse mesocolon about 35 centimeters from the trice. We transect the proximal jejunum here with a stapler. We measure about 60 centimeters of the roux limb. And this is the jejunal jejunostomy being created. This is a standard side-to-side staple jejunal jejunostomy, very easy. This is the procedure that we get the fellow to do bile anastomosis very early on in the fellowship. You can see here, we staple. This is just like any bile anastomosis here. The enterotomy is sutured with the running Vloc suture. Here, I'm trying to make it a bit faster here. This is being sutured. So this is the jejunostomy is done, and now we are doing some biliary investigation here to make sure we know where we are heading to. The patient had intraoperative fluoroscopy as well. This is cannulating the right hepatic bile duct. You can see some bile coming out from there. Again, now this is the roux limb. The roux limb is being transposed up. A small opening is made here with the robotic scissors. It is very important for the assistant to support the weight of the roux, because the first stitch is the hardest. Sometimes the weight of the roux limb is actually pull off the first stitch of the bile duct. Now you have a larger opening in the bile duct, and sometimes it tears more of the bile duct. And when you're repairing E4, oh my God, it's so painful. This is so high. And then now you have so much tension sometimes, so you really need somebody to support the roux limb with the laparoscopic bile grasper from the bedside. So once you do this, the second, third suture usually much easier. So you can see here, this is done under direct visualization here. We utilize a running stitch. We utilize a 3O Vloc suture. We like to use Vloc because once you stitch it up, it actually stays. And we do this with Whipple, bile duct repair, any kind of benign choledochoduodenostomy case, all the biliary cases we like to use a Vloc suture here. So this is the posterior anastomosis is done, and we're going to do the anterior one. You can see in a few seconds here, we start a new stitch on the 9 o'clock location. This is a new stitch, and create another knot on the 9 o'clock. Now we're doing the front layer of the anastomosis. Here, anastomosis goes. We try to see every bite that we place. So then we avoid back walling the anastomosis, because now you're going to stricture the anastomosis if you catch the back wall too. And you can see here very carefully, once we tie this, the operation is essentially done. And we place some anchoring stitch to take care of the weight of the roux limb. Okay, now this is the second video. This is the E4 bile duct injury here. So this is a much higher bile duct injury. So you can see here, like Edwin said, MRI is good. You can see here. Okay, so you can see here, this is the left bile duct, this is the right bile duct. It's not connected anymore. There's a gap there, and this is the distal bile duct. So there's a missing segment. Biliary bifurcation gone too. So again, here you can see bile, blood, whatever. You're going to see very soon here where the cut was located. So this is the left bile duct. There's two clips there. So clip being removed. And you see here, this is the right. So there's a hole on the left. This is the right anterior. This is the right posterior. So I just joined those right anterior, posterior. I just cut the septum between them to make them one stitch. Now we utilize, this is 4-O-Prolene. We try to join the duct to do a single H-shape anastomosis, so then we don't have to do two anastomoses. It's very hard to do it with a robot with two anastomoses at the same operation. So we try to do a single anastomosis here. We place 3 interrupted stitches to join them, and then now this is again the standard Roux-en-Y anastomosis here. I'm going to speed up the video. This is the same video you have seen earlier, same technique, same everything, all standardized. So now this is the rulem again, get transposed up. Like I said, somebody has to support the rulem, otherwise it's so painful to do this. And this is the first stitch going to the 9 o'clock location. And again, we always do a running anastomosis. I think if I do it open, I do parachute, but I think it's too confusing to do parachute on the minimally invasive, either laparoscopic or robotically. I think you will get very confused very quickly with the parachute technique. So I think running stitch is the way to go for minimally invasive. So again, here, this is the posterior anastomosis being created. You try to see each of the bite, try to see it. So you can see here, there's a clip here. This patient also have right hepatic artery clip. So this patient also have concomitant biliary vascular injury. Again, this is on the back wall, back side, the same technique. This is almost to the corner now, the 3 o'clock location here. Again. So now this is the front layer starting at 9 o'clock location. Again, make a new anastomosis here. We run it ventrally toward the 3 o'clock. You can see here. Okay, so the benefit of minimally invasive is I think we can see the lumen quite well and do this. I still have one video. I'm going to run it very quickly. So this is a right hepatic duct transection. I'm just going to jump to the heart here. You can see here, this is adhesions. There is a biliary stent in place. So PTC, this is the delayed repair, So this is the patient who this is a right hepatic duct only. So the left, the bifurcation is actually okay. So you see here, this is right hepatic duct only, the rest of the bile duct is good. So then we just do a route to this right hepatic duct and then do the standard anastomosis, same as I showed earlier. I think for the interest of time, I'm gonna stop here because I think I took too long already. So all right, thank you.
Thank you very much for that talk, Dr. Sakandi. Actually, I love the robotic videos. They're actually very elegant. And just speaking for myself as a young surgeon, I don't think I've gotten that comfortable using robotics to do my bile duct injuries. And so I've done a few, but I've done them mostly open. And so it's kind of cool to see your robotic techniques. Before we continue on with our third speaker, I wanted to just quickly poll the panel. So I just wanted to give you guys a scenario. So let's say we are post-op day 2 lab chole with a suspected bile duct injury that's transferred to your center. Imaging shows right hepatic arteries out. And we're talking a pretty high injury. And now we're post-op day 2. And I'll start with Dr. Jayaraja, and then Dr. Onkendi, and then we'll end with Dr. Sukandi. Would you delay this repair, or would you take them for concomitant arterial repair with a bile duct repair? Dr. Jayaraja?
So I think you're going to steal a little bit of my thunder from my talk, because I think it does depend. It does depend on whether it's laparoscopic or open to me, and if there's an associated biloma. I think those are going to be the two key factors for me as far as whether I delay or not. I personally would try to do this early if at all possible, but I would not attempt to repair the artery at that time.
Okay. Dr. Onkendi, what do you think? If you can unmute, sir. Sorry.
No, I'm saying I agree too. I mean, if there's no significant sepsis or cholangitis or inflammation, I mean, it's day 2, I would take the patient for repair for the bile duct injury. If it's a side tangential injury to the right hepatic, I would repair at the same time. If there's a missing gap like the photo I showed earlier, I would just ligate the right hepatic.
Okay. Dr. Sukandi?
So in that scenario, I always favor early repair. I think delayed repair is painful for the patient. If you leave them with the PTC hanging for 2 months, oh my God, they hate you. And I think it's a lot of logistical issues also. I mean, you know, the PTC get pulled out, they leak, they come to the ER. It's a lot of painful phone calls. So I think early repair is good. But in that case, I would not repair the hepatic artery though, but I will find where the stump, and I will offer so the stump. Because the last thing you know is you don't want to have the stump blow out like the next day or something. So I would offer so the stump and leave it not connected.
Gotcha, gotcha. Thank you for your opinions, and we'll move on to our third speaker. It's always a pleasure introducing him because he is my mentor. This is Dr. Rohan Jayaraja, and we'll be talking about delayed repair of bile duct injuries.
Thank you. Eddie, can you see my slides?
Yes, sir, I can.
Perfect. Okay, so welcome everyone. I'll try to move this along. I'm the old guy in the group over here, and so as I get older, I have less data and I have more opinions. So this is going to have very little data and more about how not to do it from errors that I have made. So let me, here we go. So the few key points. Okay, so you've heard a lot about this already: recognition, workup, associated vascular injury, and you just need to make sure that all ducts are identified. Remember, the minute this patient shows up to you, the clock is ticking with you. You are the one who's going to be for sure in a law situation of some kind. So your documentation needs to be perfect. You need to document everything, and any complications that happen after they hit you are up to you. So why early repair? Well, emotionally, this feels like one operation, right? We tend to do ours open rather than robotically. We're quite sort of aggressive robotically, but this is one area that for me personally, I just do open because I have not a single leg to stand on if this patient strictures or does anything in the future. Medical legally, you want to be as favorable as possible. I try to defend the referring doctor as much as possible and use terms like likely Moritzi's syndrome or aberrant anatomy or something like that to not hang them out to dry, because it could be any one of us. And the nice thing about early repair is that there are no tubes hanging out, and so really for this patient it should feel not much more than an open cholecystectomy. You've heard the data also that early repair does cost less, and the morbidity long and short term is better for early repairs. And, you know, we've quoted several papers over here, but basically the cost is also less. And this is obviously very user dependent because there's an implicit bias here with early repair, but it does appear that your odds of a bad outcome is less with early repair. The other factors that we use that I just alluded to are lap versus open. Certainly I'm more open to doing a laparoscopic, a patient that has been done laparoscopically, even if it's not within that sort of golden week window. Presence of a biloma, I think this is something I've learned from my other partner, Dr. Osman. Biloma is really something that's hard to deal with and portends for quite a bit of inflammation in that area. So we tend to drain those first. And associated vascular injury, as you said, should be a concerning factor for you. So basically early lap is good, late open is bad. Biloma is bad. You usually want to drain this first. And vascular injury makes you pause just because, as you've heard nicely by Iswanto, there is a higher risk of strictures down the line depending on this. I always, you know, note that the inexperienced biliary surgeon is going to say for an E1 injury, leave as much duct as possible because you want to try to leave duct for your future revision. Well, as you, those of you now know, you actually want to go high on this duct because you want everything else is coming that is coming up from below has been cut. So you're relying on the descending blood supply now. So you want to go as high as possible. And we personally always use a hep Quinard method. I'm sorry I didn't put a picture onto this, but I spatulate onto the left duct and make this anastomosis at least 1 centimeter in size. Remember, the left duct travels extrahepatically more than the right. So this is what to avoid, right? So 60-year-old biliary pancreatitis, bile duct anatomy not clear, taken to the operating room and had bile in his drain and is morbidly obese. So he's sent to me. And one thing I think that would be interesting to poll the group on, Eddie, is the use of ERCP in these patients, because everyone seems to get an ERCP and I'm not quite sure why. I mean, I think we're all hoping that it's a cystic duct leak, but you know, most of the time I think there's pretty clear evidence that this is a major bile duct injury. So of course, this is the quality of the MRCP that I got on this morbidly obese gentleman, and he was post-op day 1. And I actually, this is a case that Dr. Al-Saidi got a call from me from the operating room about. So this is what I took him to the operating room, and it was a really tough case. There was no vascular injury. And by the way, I always ultrasound, always demonstrate right and left hepatic arterial flow or absence of one or the other. I don't just rely on palpation. And then second of all, I always biopsy these livers, because if 10 years from now they show up and they say, you caused me to be cirrhotic, and I have liver biopsies of the right and left lobe that show NASH with grade 2 fibrosis, well, guess what? At least I know where I started from. I could not find this guy's posterior sectoral duct. I was in the operating room for about 3 hours, and Dr. Cho can tell you that I usually get a lot done in 3 hours, usually not just one case, and this was really concerning to me. So this was my intraoperative cholangiogram. I mean, seriously, this looked terrible, right? I mean, it was clearly, I felt like all I saw was left and maybe a right anterior duct there. So one thing I always tell all of our trainees is, however old you are, however much you've been doing this, you should always ask for an opinion. So I called my partners, I called Dr. Al-Saidi on the phone, and I cried a little bit. And I sewed to this area and kind of knew that I hadn't done what I needed to do. So this is a 6-month MRCP, and you can see that actually this is the rulum, and it's in some sort of proximity to this now right-sided duct. And so the question is what to do at this point. This is another image. He really wasn't dilated much at this point. And so finally, about 8 months later, I PTC'd this right duct, and you can see this. And they were actually able to get across into, I guess I must have done something. There was some sort of connection there. And so I went on to revise him. I actually wanted to just proceed to a right hepatectomy in this guy, but I actually Technically, that was extremely difficult. He's huge. He also has a right-sided renal cancer, by the way, and he's doing well. But this is what you don't want to do. So this is another case of a 58-year-old gentleman with acute cholecystitis, uneventful lap chole. They left a drain in place, and this is one that's ongoing right now, but I wanted to make this point because this is one of these cases where, you know, everything you've heard so far, it's pretty straightforward that you've got a bile duct injury. This is the case that wanders around for 1 year with a drain in place. And so this is what happens, right? 2 weeks later, he still has bile, so an ERCP is done and a stent is placed because there's a question of a cystic duct leak. And he's still draining. So you know that whatever's happening here is not in continuity with the bile duct, right? And your GI doctor is telling you this is a normal ERCP. I don't have the ERCP images here, but you know that something is not draining into the main duct. So then 4 weeks later, he actually gets his plastic stent changed to a metal stent, and there's no change in output still. And now he's draining about 300 cc's an hour. So the question is, what do you do at this point, right? So he comes to see me because this is actually a very, very, very good surgeon who's taking care of him, who's doing everything right, I think. And so when I saw this man, he had a metal stent in place, still draining 300 cc's of bile from his right subcostal drain. I knew what we were dealing with. And so I felt that this was an excluded right posterior sectoral duct. And so we did, and as you can see over here, and you've seen on multiple images, I felt that we were either dealing with this entity and an accessory or a posterior duct that was transected, or with this entity, an E5. I always refer to these as E5 for some reason, but really it's more of a C injury because it wasn't a concomitant bile duct injury per se. So I got an MRCP, and this is not a great image because, you know, we've got a metal stent in the bile duct, which leads to air artifact. Okay, so remember, guys, this is a T2 weighted image. T2 is stagnant fluid is bright. No contrast given for an MRCP, right? It's just a non-contrasted T2 heavily weighted image. And you can see, you'd think initially that there was a missing segmented duct, but when you actually look at the recons over here, this is the left side that's being filled through the stent, but you can see that something is stopping right here. And so what I had my IR do, because this is a hard one to hit, is inject the drain, right? So if you just inject the drain, you get the cholangiogram. So this drain has been in place for a while, and you see the cholangiogram here. And so he was able to hit it and see that this is a very big section of liver over here. And he's on his axials, he's got a tiny, tiny left liver. So we placed I didn't have an image, but this is the PTC. Imagine it in purple, because I love purple, as you can tell. And it's hanging out in the biloma cavity over here. And this is sort of that Strasbourg classification where you're going to see this accessory duct that's been clipped, you know, in the gallbladder bed, basically. So my plan for him is a hepaticojejunostomy versus a posterior right liver resection. I'd be interested to see what the other speakers think, because I'm just worried about how much liver this is supplying, and also the fact that he does not have a great left liver. So I just trying to keep things very brief to give us some time for discussion. I've shown you 2 cases of angst for me, because I think it's easy for me to show you the cases that went well. I'd rather you see the cases that did not go well. These are cases where I probably could have done a much better job in dealing with these patients. The first case had this accessory or posterior right duct that I did not find and could not drain in a very obese, big fatty liver. And the second case shows us a Strasbourg injury type C injury, where this is draining into the gallbladder fossa, and an ERCP is read as normal. And I did actually have one patient that showed up actually a year into her course with a drain in place, where, you know, she'd just been hanging out with a drain, and everyone told her that this was just a leak from the cystic duct. So delayed is not always easy. The only thing is, if you're going to do a delayed case, I would favor always having a PTC in place rather than just a biloma drain, because I personally like to sew to something blue for the delays. Remember that the definitive treatment is delayed if you wait. You have one shot at things. And I think that with concomitant vascular injury, I think one should think about, with especially a very high injury, moving to a right hepatectomy in some of these patients a little quicker than we do. We tend to, sort of try very hard to preserve the bile duct, but I think it's always reasonable to think about a right hepatectomy, especially if there's been atrophy on that side. One other thing to just mention, because Iswanto brought up the question of portal vein injuries too, I do have one patient that had a concomitant injury of, it was an E4 injury with the basically everything to the right side being taken. All I had was a twig of segment 2 portal vein and a twig of left hepatic artery. I was actually called on a weekend and got emergency privileges to go scrub in another hospital to try to get this woman off the table. And she's actually hanging out doing fine, which was surprising to me, because I thought she was going to need that right liver resected, as Iswanto pointed out. But amazingly, she's actually doing fine. And we actually PTC'd the left duct. And the IR radiologist called me and said, "I'm so happy I managed to internalize this into your rulum." And I said, "There is no rulum." But he actually had created a connection to the duodenum. So she's hanging out with a PTC in place that's looped in the duodenum. So I'm thanking God for that one. But that's all I have to say, Eddie. Hopefully we can kind of get back on track time-wise and you can get some questions. So I'll stop sharing and hand over to you.
Thank you very much for your talk. It's not always easy to share some of those kind of questionable kind of outcomes and whatnot, but it actually becomes a humongous educational tool to young surgeons like me and some of the audience that's out there. So I'm always grateful that you're willing to do that, Dr. Jayaraja. And then some of your other points, I mean, the points that you made about the actual bile duct injury was important, but some of your other comments about getting a biopsy and your comments about and the things that you taught me about how to dictate these kind of things, those are also very, very important pearls that I hope that our audience picked up on while you were talking. There are some questions that came up in the comments during all three of the talks, so I wanted to get to those. And Dr. Jayaraja, I'll get to your ERCP question in a second, but there was a question from Dr. Melissa Hogg about timing. And so Dr. Onkandi, during his talk, spoke about early versus delayed in terms of timing. And usually it's about 7 days, but I personally kind of struggled with taking a patient back to surgery when they present at 7 days or 8 days or 9 days. And so I was wondering if the panel can kind of speak about the timing of the bile duct injury and the things that they're really looking for, maybe on imaging or in clinical findings, that would kind of make you lean towards taking the patient earlier than later. We'll start with Dr. Jayaraja and then kind of move back.
Sure. So for me, again, I think laparoscopic, I'd be, at that 7-8 day mark, as long as there's not a huge biloma, or if it's drained, I'd just take that patient. I think if it was open and I was at that, 1 to 2 week mark with a biloma, I'd probably just drain and wait.
Dr. Sukandi?
I use 7 days mark pretty much in short answer. So if the patient have bile duct injury, even at day 7, I try to fix it early, and sometimes even day 7, sometimes you see inflammation, but actually not as bad sometimes. But beyond day 7, I think should be delayed, and I usually wait for about 4 weeks before I fix it. I drain the biloma, put the PTC, study the patient, make sure everything is optimized, and then do it.
Gotcha. Dr. Onkandi?
Yeah, I mean, I think 7 days probably for early repair, but I think instead of an arbitrary timing, I think as long as patient, the 4 conditions I mentioned in my talk from UCSF, where, you know, early, a full definition of the injury, making sure there is no intra-abdominal sepsis. So for me, I would say if you're, 2-3 weeks out and let's say you go for a lap washout to drain a biloma and you assess the hepatic hilum and conditions are ideal for repair, you can repair. So instead of just an arbitrary timing, I think it depends on several factors. But yeah, for majority of cases, I would say within the first week, probably is best.
Yeah, I agree. I agree with the panel. I think 7 days is a good rule of thumb to keep in mind. But in ideal situation, laparoscopic and not open or arterial injury, I've taken patients back after a week of injury to repair those. But obviously, there's some risk of stricture going down online. Dr. Sukandi really gave us a good lecture about the vascular supply to that area and the rate of stricture. That ERCP question that Dr. Jayaraja gave out during his portion, the use of ERCP, or is there a use of ERCP with pre-op workup for these bile duct injuries? We'll start with Dr. Sukandi first.
I don't use ERCPs to study the patient, because I think if you want to study the patient, MRCP is better, unless the patient cannot undergo MRI for some reasons. I think when you are sending the patient for GI to do ERCP, you are hopeful that they can do something about it, not just diagnostic.
Right.
If I know that this is a small tear, at the side of the bile duct, or the cystic duct is leaking, the clip is not tight, I send it for ERCP. I'm hoping that they take care of the problem, not just diagnostic, because if it's only diagnostic, I don't need the ERCP to do that.
Right.
And ERCP carry risk too. Sometimes they give patient pancreatitis 5%, but when you go back, it's harder for you. So I think ERCP, if you feel like they can do something about it, not just diagnostic.
Yeah, that's kind of my concern too. One of my concerns with an ERCP is, here I am faced with a bile duct injury and no way that they're going to get across the stent or whatnot, and lo and behold, the patient gets really unlucky and gets pancreatitis off of this. Ooh, a bad situation. So, Dr. Okendi, anything to add to that, sir?
I think for ERCP, you're assuming there's continuity of the distal bile duct to the proximal bile duct, but for type E injuries, there's no continuity, so it's limited in those scenarios. So for me, I think if you can get an MRCP, you're probably gonna get a full biliary tree anatomy as opposed to the distal.
Gotcha.
Well, I also wanted to make a comment. Sorry, go ahead, Dr. Kelly.
No, for the early types A, B, C, D, then you may get a full definition of the anatomy by just doing ERCP.
I think one of the things we really have to be conscious of is, we have this new group of new genre of gastroenterologists that are extremely aggressive. And there are people doing, left-sided punctures through the stomach and then rendezvousing from above and below to jump the disconnect between the bile duct. But we have to understand the problem is that they don't understand the underlying problem, which is a vascular injury to that bile duct. So yes, we can stent for a year, and that's fine. But I think that the sooner we get these patients into the surgeon's hands to direct that is also another important point, because I think that, and I have seen these patients stented and stented and stented. Now, one of the thing with repeated stenting is, and I don't have any data behind this, but I feel like it pushes the stricture up into the hilum, and it just becomes harder and harder and harder, and then you've got rock to sew to within the hilum. So again, remember, there is this really, really aggressive genre of gastroenterologists who are fantastic, but I don't know that they always understand the complete picture with regard to the long-term process for this patient.
Yeah, I agreed. I wanted to quickly mention with the comments that Dr. Al-Saidi is making fun of me because I said I was young 4 times. Just want to clarify that I'm only young in experience. I'm old in age. So I just wanted to clarify that. Going on with the next question. Since I have 3 really experienced HPB surgeons on, I had some questions about the actual technique of anastomosis. Now, you know, we talked about, and I think most of the presentations talked about bringing up a rulim and doing a end to side, but Dr. Al-Saidi just shared a good paper from Dr. Emily Winslow. I think it was in surgical endoscopy in 2019, where she describes a sideways anastomosis, a side-to-side anastomosis for these. I was wondering if we can go through with our panelists. We can talk about different anastomoses, what you prefer, some of the factors that you're looking at, where you might choose to do a different anastomosis than an end to side, whether you do hepatic duodenostomy or colorectal duodenostomy, a primary repair with a T-tube. I know that's a whole other topic in itself, but briefly, if we can kind of talk about those anastomotic techniques. We'll start with Dr. Onkendi, please.
Yeah, I think most of my repairs have been with end to side hepatic duodenostomy. I think I know the paper Dr. Al-Saidi is referring to, the sideways anastomosis, where the long-term 5-year follow-up showed structure rates, I think, of 5% with a wide patent side-to-side anastomosis. Then there was this large Danish study, which the majority of their repairs were early and they were end to side, and they were all, I think, all HPB centers in Denmark. And the it's probably a paper with the longest follow-up, I think 9 or 10 years. The structure rate was 30%. So, you know, you can argue that, you know, if you have a small duct end to side, then you're more likely to stricture as opposed to having a side-to-side wide orifice anastomosis as shown by the Dr. Strasberg team. Gotcha.
How about you, Dr. Secondi?
So most of the bile injury I fix is because it's a complete transection.
Mm-hmm.
So obviously they need to end to side.
Mm-hmm.
And I mean, you know, you can, I mean, you can utilize side to side for example, you know, large tear, and you can just sort of like place, you know, side to side. But I don't know. I think you know, at least in my hand, I can do a well end to side with good outcome. So, you know, I think, you know, you do what you can do best. You know, either open or minimally invasive. If the patient come with the open operation already, I do it open. If not, then we try to do it minimally invasively. And I utilize for open, I utilize a fluoroproline. I place the knot always on the outside. When I was in Pittsburgh, we used PDS with the knot on the inside. But when I came to Tampa, I learned from Ross McGee, and I came to realize that I think it's better to put the knot on the outside. It's kind of a bit challenging in terms of the sequence which knot goes first, because you don't want the knot to be on top of each other. So there is a method to make it smooth and sort of elegant with knot on the outside. The back side, the back wall is kind of hard to do it on the outside, but with some, you know, thinking you can do it well.
Gotcha.
With robotic, we just run it.
Got it. And then Dr. Jay Raja, you mentioned about the Hepquinot method, which obviously I learned from you. It's one of my favorite anastomoses to do, but any pearls or any decision makings that you do on the type of anastomosis that you make?
Yeah, so for me, you know, I go as high as I can and I spatulate onto the left side and make sure there's good bleeding from the duct. I think, as was mentioned, and I think we do need to make the point that you need cholangiograms to make sure that you've drained all sections of the liver, and that's important medical legally as well as, you know, obviously for the best of the patient. I personally run all of my anastomosis. It's pretty uncommon that I interrupt. I use a 5.0 PDS. I do like absorbable on the bile duct. It's interesting, Aswanta, you know, John Martini and myself actually have moved away from using VLOC on bile ducts. I've actually had a couple of strictures now for my robotic Whipples, even with big ducts. And so I'm actually moving away from barbed suture of any kind. And so I tend to use monocryl on the robotics just because it's an easier thing to handle than the PDS. And I tend to use absorbable on the bile duct, non-absorbable on the pancreas. And I usually start from one end, usually have our fellow on the right side. So we start from the left of the patient towards the right so that they're running towards themselves, you know, constantly. My own feeling with regard to interrupted and running is that, you know, the vascular surgeons run everything. The only time that they interrupt is usually when we're doing a distal splenorenal shunt to allow for growth or in the pediatric population. So in general, I tend to run.
Thank you. We have a quick question from Dr. Al-Saidi on MRCP, whether you guys think that it over or underestimates the injury. Just really quickly going down the line, Dr. Jayaraja. Oh, you're muted,
yeah,
sir.
Yeah, depends on whether there's a stent or not. So the issue is if there's any sort of instrumentation of the bile duct itself, and if there's air or metal artifact, you're going to overestimate because of exactly what I showed.
Got it. Dr. Sukandi, anything to add?
What was the question again? Sorry, I didn't catch it.
The MRCP, does it overestimate or underestimate the injury from your experience?
I agree with Dr. Jayaraja about that.
Got it. And then Dr. Onkendi?
I mean, I think that my experience so far has been it's been fairly accurate in terms of level and extent of injury. Occasionally, you know, if the patient moves and you won't get clear images, and so you may underestimate the injury. But overall, I'm not sure I've had a case where it's overestimated. So.
Got it. Well, I've gone 17 minutes over a lot of time. I apologize. I'm getting a little bit selfish because I got you guys here and I have tons of questions. So I want to just keep on picking your brains, but we do have to conclude. So maybe one final comment from our panelists, a bit of advice or anything that you'd like for us to take away from this session. We're starting the same order as we did the presentation. So Dr. Onkendi first.
I mean, my last couple of slides, I would say, you know, the key is to ensure, you know, attention-free, wide orifice, well-perfused anastomosis, like any other anastomosis in the body. So if you can, often when we get these bile ducts which are clipped or injured by electrocautery, as Dr. Sukandi mentioned, the extent of ischemia is higher than where you get a stamp. So even if it means sacrificing additional duct stamp to get to a perfused duct, you should do that as best as you can. And then what I learned from Dr. Asban, the routing of the ruling in a retrocolic paraduodenal route is probably the best way to get it to the hepatic hilum. You know, through the mesocolon of the hepatic flexure along the descending duodenum to the hilum. So.
Yeah, it's a nice route, a little bit more less tension, getting that rulem up into the right upper quadrant. Dr. Sukandi, any last words, sir?
I think two things from my end. I think when you see this, I think you need to study it as much as possible. If you have the opportunity to study artery, study it, do an MRCP, do everything. Like, make sure you know as much as possible from that case. And number two is, I want to point out what Dr. Jayaraja said earlier. A lot of these cases, they come to the surgeons actually very late. Last biliary injury I repaired maybe about 3 weeks ago, the patient had 11 ERCPs. 11, not 2, not 3. 11. I was like, I've never seen a patient with 11 ERCPs. Oh my God.
Wow.
And every time they pull out the ERCP, they stand out. The patient's strictures, like, how many times you pull out the ERCP and it's still stricture, you know?
Yeah.
Yeah.
I almost couldn't believe it. Yeah. So, obviously the patient is surgical repair, but Imagine 11 years CP, the patient get tired of it.
Yeah, no. It permanently has an endoscope down or something like that. Poor patients. That's horrible. Dr.
11 years.
Jayaraja, you have the last word, sir.
Yeah, so I think, one of the most important things to take away from this all is somebody who does this all the time should be doing these repairs. If I cut a bile duct, I am not repairing it. I'm calling one of my partners to do it. It's too emotional. So even if you know what you're doing, call somebody to do it. Third of all, please remember, don't be judgmental. Don't sit there in the recovery room or in the pre-op area and say, what a bunch of idiots, they cut this bile duct, because this happens to everyone. And I have cut a left bile duct doing a right hepatectomy, which is the HPB equivalent of this, okay? So this will happen to everyone in some way, shape, or form, so do not be judgmental. The last thing I would say is that these surgeons that refer you bile duct injuries will be your best friends for life if you handle this well. So they get a text or a call from me every day after this is repaired, stating exactly how that patient is doing, and that, patient's fine, family's fine. This is an emotional, horrible, horrible thing. Somehow cutting a ureter, doing a colectomy, it's a horrible thing, but it doesn't seem as bad as cutting a bile duct. I don't know why. And so, you just have to handle these people so, so well, because it's just the worst emotional thing you can ever imagine. And I tell you, they've been the best referral sources for me afterwards. So you just, don't be judgmental, please. If there's one thing to take away from me today, it's that.
Yeah, well said, everybody, on your pearls. And I love these practice building kind of pearls from you, Dr. Jayaraja. So that concludes this talk on bile duct injury. We'll have more coming up. We have a lot more planned, and we're trying to do this weekly. And so we'll post up the event, the time, the topics, all of that on the SAGES HPB website on Facebook. So please tune into that. I want to thank again the panelists that just devoted their time and their experience to making this session really great. So thank you to all of you guys, and everyone out there. Please stay safe. The pandemic may have peaked, but it's not going to go away anytime soon. So everybody, please be safe. Thank you very much for everybody, and have a good night.
Thank you.
Thank you, Ed. Thank you. It's great.